My name is Hiva. For those of you who don't know me, I'm a family nurse practitioner and I am the director of advanced practice here at Archer Review. Today's webinar is focused on cardiovascular review, and I am just getting over a illness, so please excuse me while I chug my Gatorade during today's webinar. I'm not fully myself yet, but this is a really important topic that I didn't want you guys to miss, so I wanted to make sure we squeezed it in today. I know this is a big peak season for most of you. A lot of you are getting ready to graduate, either already have sat for your boards exams or getting ready to sit for your boards. And I know it's a scary time and an exciting time, but this is a really important topic as we enter our clinical practice and really have to be mindful about how to assess and identify those cardiovascular risk factors for our patients and help mitigate those risks, right? So that's what we're going to talk about today. For those of you who haven't joined my webinars and you don't know much about me, like I said, I am a nurse practitioner. I'm a family nurse practitioner. I've been an NP now for 10 years. I've been in nursing prior to that since 2012. In my background, I started off in community health, which is my love. And from there, I stemmed into internal medicine. I also specialized in cardiology and endocrinology. And now I'm back to my roots of community health. And this webinar is really intended for primary care. So you don't have to be an expert in cardiology. I really want you guys to make sure you're practicing within your scope. That's really important. But we are going to talk about some things that I want you to be able to identify, and don't be afraid of co-managing patients with your specialty partners in the community. So we're going to talk about that today as well. Before we jump in, so today I'm going to cover some of the basics and really go through what I think in terms of clinical pearls we should be thinking about as clinicians, as primary care clinicians, when we're talking about metabolic syndrome, hypertension, hyperlipidemia. I even threw in some coronary artery disease and heart failure for you guys. I really want you to see the full scope. Before we jump in, I do want to remind you that if you join us through our Zoom account, you are eligible to get that one contact hour if you stay for 80% of the course. If you're not joining us through Zoom today, don't sweat it. You guys can always plan for it. We have a full calendar in July of some really great content coming up in our webinar series. So that's why we want to squeeze this one in today, just because July is really full. So just plan for joining us through the Zoom account in July. I think that'll be really beneficial because then you can get those contact hours while you're also preparing for clinical practice. You don't have to think about it. You can just store it away. With that, so again, some learning objectives for today. I really want to talk about the basics of primary care and helping you really identify some of those common cardiovascular conditions, some common risk factors, and how we can mitigate that for our patients. I want you to be comfortable explaining those assessment and diagnostics, and then also talking about management strategies when we're trying to help mitigate that cardiovascular risk in our adult patient population. And lastly, safety is always top of mind for us as clinicians. So I definitely want to make sure you guys understand those red flags and those warning signs and know when to refer to higher level of care. Do not practice beyond your scope. I was at the AANP conference last week, and I think when you get to the point in your career that I've gotten to, you've been practicing for a little while, you start to really think about nurse practitioners and our role in the healthcare system. You start to feel really energized and proactive about advocating for our role. And so I really want you guys to know that this is a valuable role in the healthcare system. You guys are going to be able to take care of a lot, but we really should not be afraid to say, you know what, this is when a specialist with more training needs to be looped in, and we need to co-manage. We need to work together to manage this patient. They're very complicated. So I don't want you guys to be afraid to advocate for yourself in that clinical setting. And that is also one of my passions, is really working with students one-on-one to help you advocate for your role, because it is an important role and it's a beautiful role. So I want you guys to feel confident and know exactly what your scope of practice is and exactly where you can push to advocate for that scope. So for our webinars, we are going to play around with Slido. I can't get our Instagram and TikTok to work this morning. It's probably still my recovery. My brain's not fully 100%. So I apologize for that, but I am looking like we're streaming on Facebook and YouTube. So that's good. So I like to use Slido because it's a nice way for us to engage on one platform while everyone's kind of participating on different platforms. So for those of you who've used it before, you know you can scan this QR code and it'll take you straight to that poll. For those of you who can't scan a QR code, you can also go to slido.com and just put in the hashtag CV review, and it'll take you to the first poll today. And for those of you who are not familiar with Slido, this is all anonymous. You don't have to put in your name. Your name doesn't pop up when you put in answer responses, but it's a nice way because I'm going to ask you guys some test questions around cardiovascular disease. So it's a nice way for you to engage with our webinar and also for me to get to know who's in the audience so that I can tailor the presentation best to you. So go ahead and let me know who's in the audience today. Are you a nurse practitioner student? Are you an RN thinking about going to NP school and wondering if this is the right track for you? I also do a lot of mentoring in that perspective as well. It's really nice to do the legwork to make sure that you understand what the role is in advanced practice and that is what you want for your career. And then for those of you who are in school and need that support, that additional support, that's always lovely. I love working with students to make sure that you're getting the most out of your education. And then of course, students who are getting ready for their boards and getting ready to enter their clinical practice. I love working with you to make sure you're not only boards ready, but you're finding that right role, that supportive role, and you're thriving in that clinical, and those, especially in those first few years where it is going to be a huge learning curve. I had that support and I'm grateful for it. And I definitely enjoyed giving that back and being supportive to my future nurse practitioners. If you guys are new to the Archer community, that's what we're big on here. No more nurses eat their young. It's a lot of let's nurture our young, right? And support you guys and create a safe space where you can ask questions, make mistakes, because you learn from those mistakes. If you don't make mistakes, if you don't have the opportunity to make mistakes, you're not going to be able to learn as efficiently. So this is really a safe environment that we try to create here at Archer, a community that you can really feel like you can be open and be like, you know, this is tough for me. Who can help me with this? And we'll help you with that. So I'm seeing in the audience, we have a couple of graduate students sitting for boards next week. Congratulations. That's a big, exciting time. I'm sure you'll do great. Taking boards soon. And then my student, Malin. Hi, Malin. Great to see you from North Carolina, ready for the boards. You are ready, Malin. Malin's been doing great. She's been working so hard. And you are ready, girl. So I am really excited to see you guys in the audience. So it looks like most of us right now are NP students. So this will be a nice little review for you guys, and we'll talk about some of those clinical pearls as well. Excuse me, I'm going to take a sip of this here. All right. So first and foremost, metabolic syndrome. I like to start off with metabolic syndrome because I think it's underrated. I think a lot of providers forget about metabolic syndrome, and it is really underdiagnosed. And why is metabolic syndrome important? Because it really does help us identify those risk factors and be able to focus on mitigating those risk factors so that our patients aren't developing those cardiovascular complications. So it's really metabolic syndrome. It's also known as insulin resistance syndrome or metabolic X. You might have heard of it. And it's a collection of metabolic abnormalities that we identify, and it really does increase the patient's risk for developing things like heart disease, stroke, diabetes. So we definitely want to address it early. This is the way I think about this is like, this is my pre-diabetes bucket. I really want to do a lot of focus on patient education so that we can really work on these buckets so that we're not developing those chronic conditions. So first and foremost, I want to point out, and you guys have probably heard this a lot in your education, is about obesity, the obesity epidemic. It's very real. In the United States, about half of our adults are considered obese. So if you look at the criteria in the category, you look at your patients and they come in, you have your vital signs in the appointment, almost half of them really qualify as obese. And then we're seeing our children, that I think that statistic is probably creeping up even more, but we're seeing it in our pediatric patient population too. And we're seeing a lot more of these chronic conditions creeping up in late adolescence as opposed to just middle adulthood and older adulthood. And so we really have to nip this in the bud and figure out what's going on. How can we get our community more active, more healthy, so that we're also not only living longer, healthier lives, but also reducing the overall burden in the healthcare system, right? So the healthcare system really needs to be focused on that early prevention piece so that we're not treating so many patients once they've reached already that disease state. Metabolic syndrome really affects both male and female patients equally. So there's not one that's more affected than the other. Obesity is a big risk factor. And so when we're looking at the criteria, any 3 of these 5 criteria, your patient does meet metabolic syndrome, and you can go ahead and put that in your ICD-10 and have it in their chart. I think most providers just underdiagnose just because they tried not to label patients with things, but this is really our job. So that way, when other clinicians see them, they say, okay, this patient has these risk factors, and you can all work together to really help this patient minimize those risk factors or work on reducing those risk factors. But really, obesity is big, huge. Number one, causes a lot of things like insulin resistance, more on a cellular level. If you guys have been watching the webinar series, the last 2 I gave were on diabetes. The first one was on the pathophysiology, and the second one was on the pharmacology. If you missed it, go back and watch those in our Facebook group for free or our YouTube channel. But basically, when patients have that obesity, especially that central obesity, that waist circumference is really high, we get really a lot of insulin resistance on a cellular level. So oftentimes in clinic, most clinics don't measure a waist circumference. You could make it part of your practice, really work with your medical assistant, coach them on what you want done for your visits and what type of visits you want things done for. So like for my patients who come in with acute eye complaints, I always have my medical assistants make sure they're getting a visual acuity when they're doing their vitals. So I have that when I'm going into the room. It really helps with the flow of your day as well. So there's not so much back and forth of you're having to repeatedly go back and forth into one patient room. So you can work with your patients if this is something that you want them to do. You can work with your medical assistants and train them and say, we're going to make it routine that I want that waist circumference measured on my overweight or obese patients. And then patients will start to get more familiar with that process, and you can talk to them about it too, because I know that's a sensitive subject for a lot of patients, but you can explain to them that it's part of your taking care of their overall health. And then also elevated triglycerides. Remember those triglycerides, we'll talk about this a little more, but over 150, I start to really think about what's this patient's diet like, right? What's their liver look like? Are we dealing with some fatty liver now? I want to look at their liver function, but we really want to make sure that we're eating well, we're exercising and getting those triglyceride levels down. And if we can't, we're going to use some pharmacology. And then also, if they have reduced HDL, remember HDL goes up the more active your patient is. So for men, if it's less than 40, for women less than 50, then I know that that patient needs to be doing more exercise. We're seeing a lot of research now that a sedentary lifestyle is similar to what smoking was like 50 years ago. People are just starting to understand in research, scientists are just starting to understand how bad a sedentary lifestyle is. And I know we're all guilty of it because we're all busy. We all have a lot of work to do in front of computers, I myself, and it's tough. That is really bad for your cardiovascular health. So we really want to get those HDL levels up. And then we also want to look at their blood pressure. So remember, we're going to go over some blood pressure guidelines, but if we're seeing their blood pressure elevated, this is stage 1 hypertension. If we're seeing early signs of hypertension, if we're seeing early signs of diabetes, we really want to make sure we're addressing those things. So again, any 3 out of 5 of this criteria really does meet the criteria for metabolic syndrome. I don't want you to feel shy about diagnosing your patients with metabolic syndrome to help prevent those chronic conditions. Management, biggest thing for management with pre-diabetes, metabolic syndrome, early stages of hypertension, we really want to talk about lifestyle. So let's get to know our patients. What's going on? Is it more due to a sedentary lifestyle? They're eating out a lot. They're not eating well, high caloric diet, fatty diet, weight loss. Weight loss is a huge modifiable risk factor that we can modify, right? So weight loss, helping our patients with weight loss, either through diet and exercise or with diet and exercise and pharmacology, those GLP-1s we talked about last week. We really want to make sure that first and foremost, first line is always managing those modifiable risk factors, the lifestyle modifications. I hate being sick, you guys. It's like I can't drink enough water. My mouth is so dry. Okay, so we definitely want to manage those comorbidities to help take some of that pressure off of the heart, right? So hyperlipidemia, we don't want them developing that plaque in the arteries. Hypertension, we don't want that pressure on the arterial walls. Insulin resistance on a cellular level also puts a lot of pressure on the pancreas. And obesity, we talked about. Medications, we're not going to go too in depth about that right now, but definitely we're going to hit statins, antihypertensives in this lecture, metformin, GLP-1s we talked about in our diabetes lecture earlier in the month. So hypertension, what is hypertension? When you're thinking about these diagnoses, I want you to be thinking about the pathophysiology. What's happening with this patient? What's happening in their body? Because once you understand that, it's really helpful because you can then educate your patients on it and they'll take their health more seriously. It'll make them more active to follow the recommendations that you're making. So hypertension, what is it? Why is it so bad for us? It's really more force. It's that force of blood against those arterial walls. And over time, if that force is consistently too high, it's going to put a lot of strain on the heart to get that blood pumping out. It's going to put a lot of strain on those arterial walls as well, right? And it puts a lot of strain on those end organs that are relying on this blood to get the oxygen, get the energy that they need. So it really is multifactorial. It impacts a lot of different things, and it can lead to heart disease, like chronic heart disease, stroke, and also kidney disease. Chronic kidney disease, hypertension, diabetes, those are huge risk factors for chronic kidney disease. So it puts a lot of pressure on those end organs, and we'll talk about it as well. But it's worldwide. It's a silent killer because oftentimes when I start talking to my patients about their blood pressure, you can look at historic vital signs when patients come in. And I always like to do that because it's not just that one visit. I want to see how they've been trending, right? Is their heart rate high? Is their blood pressure always high? Let's talk about how it's trending. And when you're diagnosing, you can use those trends to diagnose, right? You have a record of it. And if it's more than 2 to 4 weeks apart, you're like, look, this has been pretty consistent for the last couple of months. Your blood pressure is high. Let's talk about this. You can diagnose based on previous vital signs as well. And my patients will be like, oh, but I feel fine. And that's what's dangerous about hypertension because patients don't become symptomatic until it's been prolonged for a very long time and not treated for a very long time. It's causing remodeling. It's caused its damage already. So I really talk to patients about that because I'm like, you're feeling fine now. I want you to stay feeling fine, right? That is my goal. I want to work with you to make sure that you're living a long, healthy life. So we really want to talk to them about the fact that they're not going to see many signs and symptoms until it gets bad. And there's a high risk for cardiovascular disease, MI, stroke, death. We really want to help mitigate those risks for them. Now, in terms of definition, you guys are probably familiar with this. AHA defines blood pressure in these categories. They did update it back in 2017, a few years ago. So they now have been a little bit more strict with the categories. Normal is anything under 120/80. And now we have this elevated category, which is between that 120 to 129 range. And anything above 130 over 90, sorry, over 80, we really do classify as stage 1 hypertension. Now, the reason for this, it's really important because when I was entering clinical practice, this was still in that elevated range, right? You still were not considered stage 1 hypertensive until you were in that 140, 190. We've gotten a little bit more strict because we're really seeing that the patients are going undiagnosed and untreated. So let's be a little bit more strict about these categories and these guidelines to help reduce those cardiovascular conditions, right? So we definitely want to talk to patients about getting their blood pressure down to that normal range, 120 over 80. And again, remember, if either is high, they qualify. So if their systolic is 130, but their diastolic 72, that's still stage 1. If their diastolic is 84 and their systolic is 118, that's still stage 1. So either one, either the systolic or diastolic, does qualify for that category. Hypertensive crisis. So if you have a patient with blood pressure coming in that's high, a 180 over 120, you really want to start asking questions to see if there's any signs or symptoms of end organ damage. That'll give you a better sense of, is this urgent or emergent, right? There's a distinction between that. But we really want to figure out what's going on with that patient when they're coming in with that high blood pressure. And this is one thing I talk to my new NPs about. You want to make sure that you're in a clinical setting where you can consult someone who's experienced, whether it's an experienced NP or an experienced MD, DO, whatever it is. Because in those clinical scenarios, you want to figure out this is what I'm thinking. Would you do something differently? You want to be able to bounce those ideas, especially those first couple of years in your clinical practice, off another clinician, so that you're making sure that you're doing the appropriate intervention for that patient. It's a huge learning curve. So don't be afraid to ask questions. If anyone's making you feel like you can't ask questions, that is not the right environment for a new grad. All right, so JNC8 is a little outdated. Last time they updated these guidelines were in 2013, 2014. My apologies, guys. All right. So take it with a grain of salt, but it's a nice little table to be thinking about, especially when you're first entering clinical practice and you kind of need a little bit more guidelines on how to prescribe. It's really nice in that sense. So remember, in your general patient population who's healthy, under 60, we're going to try to get them under 140 over 90. If we have patients who are diabetics or have chronic kidney disease, remember, we want to try that those kidneys get hit really hard, along with other end organs like your brain, your heart, that those kidneys really take a lot of most of the brunt. So we definitely want to make sure, regardless of age, even if they're over 60, if they have diabetes or chronic kidney disease, we want to get that blood pressure down. And then ACEs and ARBs have really good renal protective properties. So even if it's a low dose ACE or ARB, like 5 milligrams, I still try to get my patients on an ACE or an ARB to protect those kidneys. Now, with our patient population, our geriatric patient population, and of course, a lot of our patients are going into that baby boomer age group and they're aging. So we see a lot of geriatrics in primary care now. The boards heavily focuses on geriatrics as well, from what they say on their website. So you really want to be thinking about geriatric implications, what's safe, what's not. In our patients and our geriatrics who are over 60 and don't have diabetes or chronic kidney disease, we can start to loosen up that blood pressure goal a little bit. And the reason for that is because researchers finding that it's more dangerous for them to have low blood pressure and not get that perfusion to their brain, so that if they do have too low blood pressure, which I commonly see in my geriatric patients because they're taking their medication and they've been taking it for a while and no one's looked at the dose, they can really get dizzy, lightheaded, which already happens as part of the normal aging process, and have falls and get in the hospital and not be able to get out. So we definitely want to make sure that we're being a little bit more less aggressive with their blood pressure as they're aging. And like I said, the JNC8 guidelines are pretty outdated. They do recommend starting patients who are African American or Black on thiazide diuretics or calcium channel blockers. I personally don't go by that. The boards does want you to, they do say that they want you to use the guidelines. So just think about it when you're answering board style questions. You do want to go by JNC 8 guidelines, but they're not going to try to trick you. And in clinical practice, you really want to look at your particular patient and look at what's going to be the best fit for them. And I'll talk to you guys a little bit about side effects and profiles so that you can really find the best fit for that particular patient, regardless of their ethnicity or race. And then in terms of blood pressure, I'm hearing from a lot of preceptors in the clinic setting that new students, new grads don't have those clinical skills that they expect. And so I know as a nurse practitioner, you're likely not going to be taking your own vitals. Somebody's going to be rooming your patients for you. But I want to make sure that you guys understand how to take a manual blood pressure, because oftentimes our medical assistants also are coming out of school just being trained on doing blood pressures on machines. And there's not a day in clinic where I don't check a manual blood pressure myself. And the reason for that is because when patients come into the room, they're anxious, they're running in, they're sprinting in, they're usually late, they're chatting with the medical assistant. You're not really sure about the form. Again, you can train your medical assistants about proper technique, but you're not really sure about the form that the blood pressure was measured. So you want to make sure once you enter the clinic, once you enter the patient room, you are talking to the patient, they've been sitting down for 5 minutes. You then, when you're doing your physical exam, after you guys have talked through your history and you're ready for your physical exam, you can check the blood pressure manually yourself and see if it's a true elevation or not. That's always really more effective and more accurate. And I love to do that because oftentimes it's super high, patients get anxious about it, and I say, it's okay, I'll check it myself and we'll make sure that it's truly high. If it is, we'll address that. But sometimes when you're running in, you're anxious, talking, it'll be high. Those are normal. That's why we want to make sure people are sitting for 5 minutes, legs uncrossed, flat on the ground, arm at heart level, and you're doing your own manual blood pressure. So make sure you guys are practicing that on family members, loved ones, your medical assistants. You guys can practice back and forth, but make sure you understand the proper technique for taking manual blood pressure. In our clinical skills videos on our on-demand page, you can purchase those advanced clinical skills videos, and manual blood pressure is one of them. So don't miss out on that one. Don't feel like, oh my gosh, I don't know how to take a manual blood pressure. My assistant usually does that. You guys have all those resources in our on-demand page, and you guys can practice it on friends, family members, or in your clinical practice. The other thing I was going to talk about is if you have a patient who's consistently high in the office, and patients have learned white coat syndrome as a phrase, they love to say it because they don't want to start medication. You really need to work with those patients to make sure we're getting those home logs. And you want to talk to patients about proper technique of measuring blood pressure so that you're getting accurate home logs, and then make sure they're following up. So don't let them be lost to follow up and then months later it's chronically continuing to be elevated. Nobody's treating this hypertension. So you want them to come back in, whether it's with you or if you have a nurse that does these blood pressure nurse visits, you want them to come back in with those home logs, and let's look at those logs together. Masked hypertension is the opposite. It's when blood pressure is normal in the office but high at home. This one's a lot harder to diagnose because patients will typically tell you historically, like at home, like, oh, sometimes I feel really dizzy or I kind of feel off. One thing as part of your differentials that you can think about is, could this be masked hypertension? It is a lot harder to diagnose, but if patients typically are maybe symptomatic at home, one thing I typically ask them is to start measuring their blood pressure and their pulse and see what's going on when they're symptomatic, along with other diagnostics that we're going to order to evaluate whatever that symptom is, whether it's they feel dizzy or get chronic headaches, chest pain, anything that could be related to chronic hypertension that's being masked in the office. And then, of course, with those readings, you definitely want to make sure you're spacing them a few weeks apart so that you can make an accurate diagnosis. Typically about 2 weeks apart, and 2 separate readings is enough to make the diagnosis for hypertension. Etiology, a lot of it is categorized in either primary or secondary. Primary are those not those non-modifiable risk factors. It includes both. So primary hypertension could be due to environment if the patient's in a really stressful environment. Genetics is a big one. It's always usually, genetics outweighs whatever you're doing in terms of lifestyle. I remember one patient who he was a marathon runner and very healthy and just had really high hypertension, genetics, big factor. That patient, absolutely want to get them over to cardiology, because cardiology will do a full workup of their genetic background and do a full workup of their cardiovascular risk. And then you can co-manage that patient with cardiology. Very important. But genetics does play a big role, but behavioral causes of hypertension are huge too. Smoking, we all know smoking is a huge cardiovascular risk. We definitely want to make sure we're asking the questions and we're talking to our patients at every visit. You can note in your visit note that the patient's not ready to quit, but you have talked to them about it. And maybe the 20th time you ask them, they're like, you know what, I really should be doing something about this. But you want to make sure you're asking at every visit, and then you're addressing those other lifestyle modifications as well. Secondary, if you're considering a secondary cause of hypertension, you really want to get them over to the specialist to do a full evaluation. But typically with these patients, I would be thinking about, I've been treating them for a little while, we can't get their hypertension under control, and I'm thinking maybe this could be secondary, maybe it could be due to underlying kidney issues, maybe it's an endocrine issue, although we're going to screen for that when we're first diagnosing hypertension. But I definitely want to get them over to the specialist if you're suspecting a secondary cause of hypertension. And then those hypertensive emergencies, again, if someone has rapidly elevating blood pressure, you absolutely want to ask those questions about end organ damage and get them to the appropriate level of care. What we're really trying to prevent is damage to the heart. Most of us know that LVH, or left ventricular hypertrophy, is one of those first signs on an EKG when patients have chronically uncontrolled hypertension. But patients can also get other issues too, like aortic dissection. Remember that pressure on those arterial walls, right? Really starts to stretch out those arterial walls, and you can get a lot of things like dissection, valvular disease, coronary artery disease, especially if they also have some hyperlipidemia. We also, our eyes, so a lot of microvasculature in the eyes. So we start to see signs of retinopathy. This is why it's really important for our patients to make sure they're doing those annual eye exams. But also the brain. We want to make sure we're perfusing the brain adequately. We're not putting too much pressure on it, so we're not getting vascular or hemorrhagic dementia, but definitely cognitive impairment due to poor blood pressure control. And again, those kidneys get hit really, really hard. So history and physical, you want to ask those questions: family history, past medical history, social history, what medications are they on? Physical, you're going to do your own blood pressure check if it's high. You also can look behind their eyes. Honestly, this will come up on your boards, but I've never seen cotton wool spots in my life. Maybe I don't do a good enough job with the optic exam, but it's hard in primary care. And now they have the technology to really be able to dilate the eyes and look in the back and look for any retinal, any signs of retinopathy, or see any of those cotton wool spots. So I really just make sure that my patients do go to the eye doctor every year. That's part of my routine questions when I'm talking to my patients. And then cardiac, of course, you can listen for any carotid bruit if patient has all those risk factors, and you want to make sure that there's no plaque buildup in those carotid arteries. But by the time we're seeing left ventricular hypertrophy, this patient's had hypertension for a long time. Thyroid enlargement. So if we have a patient with hyperthyroidism, we definitely want to be suspecting that and screening for that with new diagnoses of hypertension to make sure it's not a thyroid condition that we are missing. So that initial workup, labs that I like to do a CBC. I like to look at their hemoglobin hematocrit. If it's elevated, I'm also suspecting that it could be some sleep apnea causing some hypertension. So if we fix the sleep apnea, we take the pressure off the heart. We also want to look at that chem panel along with the electrolytes and the liver function. We really want to look at the kidney function. So what's happening? Is there any damage we need to watch for? You can also do UA and look for any signs of proteinuria. And then A1C, especially if we're looking in their serum glucose, is a little bit high. Okay, it was not fasting. Let's look at their A1C. What has it been over the last 3 months? Definitely want to screen for thyroid, make sure we're not missing that. And then let's look at their lipid panel. What's going on with their cholesterol, their triglycerides? What do we need to do to help this patient really not get to those end stages? 12 lead EKG is really provider specific. I like to get 12 lead EKGs, baseline 12 lead EKGs on my patients. I'm lucky in the sense that in the clinical practice, you don't have to build the 12 lead, and most of the providers are like, yes, you definitely want to get the baseline and scan it into the patient's chart. You don't have to build them for it. It's just good care. But you really have to figure out what you can do in your clinical setting. But baseline 12 lead EKGs are nice to have because once patients get to that point where they've really aged and things are happening, they're becoming symptomatic, you have something to compare it to. So again, first and foremost, lifestyle modifications, smoking cessation, stress reduction, exercise, all things we know as clinicians, and we really have to work with our patients to make sure that they're working on these things as well. My new push is, why are we not demonstrating the healthy lifestyle as clinicians? So maybe in future webinars, I'll also advocate and talk about that a little bit. But again, we all know the science behind an active, healthy lifestyle, Mediterranean diet, limiting alcohol, getting that weight down, smoking cessation. It's the same conversation we want to have with our patients. Antihypertensive medication. So again, you can follow JNC8, especially when you're first entering clinical practice or answering those board style questions. But just to tell you a little bit more about the categories of these medications, of the classes. So you have your ACE inhibitors and your ARBs. Remember, those have renal protective properties. So your ACE inhibitors end with the suffix pril, and your ARB ends with the suffix sartan. And both of them can cause dry cough. So that's not going to hurt your patient. Some patients get bothered by it. Some patients may have a dry cough, mostly with ACE inhibitors. I'll switch them to an ARB and it'll go away. So you can kind of play around with that. But the dry cough is an expected potential side effect. Again, it's not going to harm them, but some patients get a little annoyed by it and want to switch to a different class of medication. Biggest contraindication. So whenever you're studying pharmacology, you want to be thinking about, how does that class of medication work and what are those contraindications? Safety first. Biggest contraindications. So we would not be prescribing ACE inhibitors or ARBs in our childbearing women. And the reason for that is because there are huge negative effects on that fetus. And so if I have a patient who's of childbearing age, you need to have that conversation with them. Are they planning a pregnancy? What's their family planning like? If they're not sure, or if you're just nervous about starting them on an ACE or an ARB, you can start them on a beta blocker that's safe in pregnancy, labetalol. It doesn't work as well with lowering the blood pressure, but it is safe because we definitely don't want our pregnant moms on ACEs or ARBs. Angioedema is also not expected, but a potential contraindication. I had one patient come into my office with angioedema. After assessing her airway, I looked on her medication list and she was not on an ACE and ARB. And sure enough, when I called the ER, when she was on her way, I was giving verbal report. The nurse asked, is she on an ACE or an ARB? So something that you always want to be thinking about if you have a patient who calls with signs and symptoms of angioedema or walks into your office like I did with signs and symptoms of angioedema, but then you do need to get them over to the hospital to make sure that their airway is safe and we can safely get them back down to normal, but it is a potential adverse effect of ACEs and ARBs. Calcium channel blockers work really well. Biggest side effect with calcium channel blockers is lower leg edema. So if I have a patient who already has a little bit of ankle edema, I steer clear of calcium channel blockers just because it's going to make it a little bit worse and they won't be happy with me. Thiazide diuretics also work really well, but that patient's going to be urinating a lot. So you do need to educate them on making sure they're taking it in the morning. So as they're going about their day, they're peeing and not really noticing it. If they're taking it at bedtime, then they're going to be waking up in the middle of the night and they're going to hate you. So you want to make sure you talk to your patients about potential side effects and when to take them and how to take their medication. That's definitely in our scope of practice. Last thing I'll say about beta blockers. So some patients may not tolerate beta blockers very well because it does reduce that heart rate as well. So some patients might get really sleepy, tired, fatigued. So just be mindful of beta blockers. It's not my first line, but if I'm really thinking someone is considering pregnancy, or I'm worried that they're not using any contraception or any methods of preventing a pregnancy, and it's a new diagnosis and their childbearing age, I might steer more towards a beta blocker, but it's not my first line just because patients don't tend to tolerate it very well. So again, here are those treatment guidelines that you guys can look up with JNC8. And biggest thing, signs to refer to cardiology. So again, if you have a patient where you've been working with them for a little while and their hypertension's just not coming down, and you've tried multiple medications, you've done medication adjustments, then that's somebody I definitely would get over to cardiology. That could be potentially secondary causes of hypertension. Also, if that patient has any family history or any history of cardiac conditions themselves, I want to be co-managing that patient with cardiology. Absolutely. Pediatric patients, OB patients, always also co-managing. Pediatrics always goes to pediatric cardiology, and OB will also be managed by cardiology as well as an OBGYN. All right, you guys, let's practice. Wow, I talked a lot about hypertension. Sorry, I'm chatty today, I guess. I missed you guys while I was out. Oh, and I forgot to do my poll. I'm not 100% today. I'm sorry, you guys. So I meant to have you guys tell me how confident you felt before the webinar. So if you can, for 2 seconds, tell me, because this helps us with our CEs, with our credentialing, to show if you guys have learned something from the webinars. So how confident were you feeling before? And then I'm going to do this again after. I'm really off my game today. I'm sorry, you guys. Okay. So this is before. I'll do another one after, but this is our exam question. So let's read through it together. So Mrs. Jones, 35-year-old female, she's 6 weeks pregnant, and she's due to see her OBGYN next week. The nurse practitioner, you note on her medication record, she's taking lisinopril 10 milligrams daily. So she's on an ACE and she's 6 weeks pregnant. Which hypertension medication could the nurse practitioner consider a safer alternative? And this is a select all that apply. That's what SATA stands for. So she's on an ACE inhibitor. You, as a astute clinician, know that ACEs and ARBs are very bad for the fetus. And this happens in clinical practice. This has happened not to my patient, but in the clinic I've been in with another nurse practitioner. And patients will get pregnant on those ACEs and ARBs, and they'll tell you, no, I have no plans of pregnancy. And sure enough, they come in and they're on that ACE or ARB and they're pregnant. So you have to be really astute and look at their medication list every time and switch them to make sure you're practicing safely and keeping that baby safe. So what do you guys think? A, B, C, or D? Can you put them on labetalol, methyldopa, nifedipine, or losartan? A, B, C, or D? Thank you for writing it out. You guys are right. A, B, C, or D. The acronym you can remember is LMN. So typically I would switch this patient over to labetalol, but you can also do nifedipine or methyldopa. But we definitely would not do losartan because that is an ARB. So when you're studying for boards, when you're thinking about clinical practice, studying for clinical practice, you always want to look at the medications and make sure you understand which class of medication it's in and what its mechanism of action is, and what those potential side effects are and what those adverse effects are. That's going to be really helpful in practicing safely. All right, given the timing, we're 45 minutes into the lecture. I'm going to go a little bit faster through hyperlipidemia and see how far we get. But I don't want you guys to miss out on this content because it is peak season. So hyperlipidemia, you guys probably know by now that the definition is elevated LDL or total cholesterol or triglycerides or any combination thereof. Remember, your total cholesterol is your LDL and your HDL added together. So be mindful of that. If you have a patient who's really healthy, their LDL is under 100 and their HDL is really high, which I've seen a lot, their total cholesterol is going to be high. So you really have to be able to interpret what you're seeing in these lab values, and just don't say, oh, it's total cholesterol is over 200. This person has hyperlipidemia. No, their HDL levels are really high, right? You need to be able to break that down. And then when I see triglyceride levels above 150, I'm really honing in on diet. I want to find out, what are they eating? How much alcohol are they drinking? What are their liver function looks like? I want to make sure that we're avoiding or catching any early signs of fatty liver disease and talking to them about how to bring their triglyceride levels down. Two types of hyperlipidemia, primary and secondary. Primary is going to be those non-modifiable risk factors, mostly like genetics or familial risk. Secondary are going to be those modifiable risk factors, and we'll talk about that. Most common in patients ages 40 to 59. However, I do always ask in my 30-year-olds as well about family history and if I need to start screening earlier, because we definitely don't want to miss that early on. That's a whole decade. You can use this ASCVD calculator. I really like it because it does not only give you that 10-year risk of having a cardiovascular event, but it also factors in things like, do they have hypertension? Do they have diabetes? Are they a smoker or former smoker? It's a really nice risk calculator that you can talk to your patients about, and it also gives you advice on what you should do that's evidence-based in terms of pharmacology to help minimize that patient's risk. So it's a nice tool to have. You can use MD Calc has it. That's what's on my phone. The limit with this risk calculator is that it only factors in patients within that age range of 40 to 75. So it is limited in that sense. Statin intensity, you guys know that it comes in low, moderate, and high intensity. And this is a nice little chart summarizing all that. If I have a patient where their ASCVD risk is high and I need to get them on a high intensity statin, I won't start them right away on high intensity. I want to see how they're going to do, especially if they've never been on a statin before. What I'll probably do is start them on Crestor 5, which is moderate. And patients love those low numbers because they think they're taking like a little baby dose of something. And then if they're doing fine, I'm not seeing any adverse effects or any side effects, then I can slowly start to bump them up and get them to that high intensity in a couple of weeks. So there are different pharmacologic treatments. Statins are going to be our first line. PCSK9s are a great alternative if patients start to have side effects of statins and can't tolerate it, or if their cardiovascular risk is just so high. I'm going to send them over to cardiology, and cardiology will probably start them on a PCSK9. But we also have other options too. They're not as effective, but they can help lower things like triglycerides and overall cholesterol levels. Statin side effects we really want to watch for is rhabdomyolysis. I'm so tired today. I'm sorry, you guys. Rhabdomyolysis. So rhabdo can happen at any stage. So I have patients who've been on statins for a long time, and then all of a sudden they start having that muscle cramping, and it's early signs of rhabdo. I send them to the ER, make sure their kidneys are well hydrated, and we stop the statin. Now, that doesn't mean you should leave your patient untreated, right? So you can try a different statin, or if you're nervous about it, you can send them over to cardiology, and they'll probably start them on the PCSK9 or other medications. But we definitely want to make sure that we're aware that this is a potential side effect at any stage, even with patients who have been on statins for a long time. We also want to look for any signs of elevated liver function. Typically, you will get some elevated liver function with statins. That does not mean you should stop those statins. That is an expected finding on that chem panel. However, if you see liver function 3 times the normal and it all of a sudden goes up, then I would be worried about liver damage. And we want to definitely assess for any signs of liver damage like jaundice, abdominal pain, and probably get that patient off a statin on a different pharmacologic class of medication. All right, you guys, let's practice again. So that poll is open. You guys can put it in there. Miss Hadley, a 47-year-old female, comes in to see the nurse practitioner for a follow-up 1 month. After starting atorvastatin 40 milligrams, she complains of new onset muscle cramps and dark urine. Which lab tests must be ordered along with a comprehensive metabolic panel of CMP today? So what are you going to assess? So which lab tests must be ordered? So they're asking you for a lab test, and they're telling you you're already ordering the chem panel, comprehensive metabolic panel. So think about what's in that chem panel and what you would want in addition to what's already in that chem panel. This is a 47-year-old female. She's here for a 1-month follow-up, started a statin, and now she's complaining of muscle cramping and dark urine. So what are the things that are top of mind for you guys? Let me know. What are we worried about with those signs and symptoms? All right, you guys are feeling confident. So we're worried about her kidney function. So out of this group, which one, A, B, C, or D, which one is going to help us further assess her kidney function? Is it her creatine kinase, her ANA, CBC, or troponin levels? What do you guys think? A, B, C, or D? All right, getting a lot of responses. You guys are absolutely right. A is the right answer. Remember that CK level really shows us that muscle breakdown. She's coming in with that muscle cramping. So we definitely want to look at her CK level and rule out rhabdomyolysis. Oh, myelinosis. Why can't I say that today? For this patient, rhabdo. I think it's because we always just say rhabdo in clinic. All right, you guys, how are we doing? 10 minutes left. Let's go through coronary artery disease and heart failure. I don't want you guys to miss out on that content. Coronary artery disease, we know that's when plaque forms in those coronary arteries, our main arteries. Remember, this can really lead to poor tissue perfusion, right? Because the heart feeds itself with those coronary arteries. So we worry about that plaque formation either partially or completely blocking that blood flow. And then when the tissue, those muscle tissues don't get the blood, they die, right? First, it'll show signs of ischemia, but then it'll turn into an infarct if it's not treated. So we really want to prevent that clot, that plaque formation. How do we as primary care clinicians prevent it? Getting that cholesterol level down, the blood pressure down, blood sugar levels down, weight loss, all the things we've been talking about today. That is our role in primary care. And anyone we're suspecting with already high cholesterol levels for a long time, family history, we're suspecting they already have some plaque buildup, we're definitely going to send them over to cardiology to do a further evaluation. They can do cardiac CTs now, which are pretty non-invasive, and they can look at those coronary arteries. It really lights it up. And they can also look at their peripheral arteries. So the same thing happens in their peripheral arteries that happens in their coronary arteries. They start to get that plaque formation. So I have patients who come in with leg pain, and that's how they describe their peripheral artery disease. But prevention is our big task in primary care, prevention. So making sure we're talking about lifestyle, but also managing those conditions so that we're preventing that plaque buildup. But genetics does play a huge role. And as we age, our patients are at increased risk as well. Autoimmune conditions, inflammatory disorders, I also want you to be thinking about cardiac disorders, does put them at increased risk for coronary artery disease. Management, non-pharmacologic, or those lifestyle modifications we talked about. Can't stress smoking cessation, physical activity, and decreased stress enough. In terms of pharmacology, we're going to be co-managing those conditions. And we're going to be managing this patient with cardiology, but we're going to get their blood pressure under control. We're going to get their cholesterol under control. We're going to get their blood sugars under control. And hopefully they haven't developed any other issues like heart failure or any ischemia. All right, let's practice. A 72-year-old male with a history of hyperlipidemia comes into the primary care clinic today for his follow-up visit. The nurse practitioner, you are an astute nurse practitioner, and you auscultate a bruit over his left carotid artery. So you're doing a good job, and you're checking for bruit in this patient who has a history of hyperlipidemia, and he's 72 years old, and he's male, right? So what initial imaging would be used to verify plaque in that carotid artery? So when you send this patient over to cardiology, you could also order this imaging beforehand. This is someone that I'd be picking up the phone and making sure they're not waiting 6 months to see cardiology. But if you're hearing that left carotid artery, that bruit in that left carotid artery, what are we going to get on this patient? Will an X-ray help us verify that plaque? A CT scan, ultrasound, or an MRI? What do you guys think? You guys are awesome. That's right. We're going to get an ultrasound to evaluate that patient's carotid arteries. CHF, congestive heart failure. Again, we're trying to prevent this in our patients. Most common etiology is coronary artery disease in patients who have had remodeling due to either an MI, an infarct, or uncontrolled hypertension. So we definitely, or valvular disease. So we definitely want to make sure, again, we're preventing congestive heart failure by treating those conditions. Also could have a little CHF, or I don't want to say a little CHF, the way I said it sounded funny, but we could see CHF in our pregnant patient population as well, just because of that increased demand on mom's body. But typically we'll see this more in our older patient population. It's more closely related to aging because these conditions will have had to be going on for a long time to really cause that remodeling in the heart. Two different types of heart failure. I think I will do a specific lecture, a CE lecture on heart failure and management. Today we'll just go over the high level, high yield stuff. But you can have right side heart failure and left side heart failure. When you're thinking about symptoms, I want you to be thinking about whether it's right side heart failure or left side, or the patient could have both, right? But that right side heart failure, that blood is not moving through the lungs, right? It's that right side of the heart that's failing, or it's a little tight, not contracting well, or the muscles beefed up. So what's happening is that fluid is backing up into the body. So that those are the signs and symptoms that we're going to see. We're going to see mostly ascites, so that fluid in the abdomen. That we can also see fluid in the lower legs, that dependent edema. With the ascites, we see a lot of anorexia. Patients aren't as hungry. Weight gains, mostly fluid, but patients will report also their fatigue. Maybe we'll see some hepatosplenomegaly as well. With that left side heart failure, it's the fact that the heart, it's that left side, which is actually more common. And so the heart's not adequately getting that blood out of the heart. So it starts backing up into the lungs. So we see a lot more lung symptoms, right? So typically with these patients, I really, with all my patients with heart failure, whether right side, left side, I want to see what's happening with their heart. I always ask about how they're sleeping and whether they can lay flat comfortably or how many pillows they need. And oftentimes with my patients with really bad heart failure, or not even that bad, they come into the office and they seem fine, and they tell you they're fine. They're sleeping in recliners all night because they can't lay flat. So orthopnea, remember, it's really backing up into those lungs, and they have to sit up to be able to breathe and sleep at night. That's a big red flag. But oftentimes we'll see more pulmonary symptoms like shortness of breath, cough, the wet lung sound. You definitely want to take a good listen and listen for any pulmonary congestion. Diagnostics, a lot of different ways. Sometimes you can see it on chest x-ray, but that gold standard is going to be an echocardiogram. Classification, remember, this is the New York Heart Association functional classification. So with our heart failure patients, we definitely want to make sure we are thinking about how functional they are, because the more they are active, the better for their cardiovascular health. So we want to get our patients active. And oftentimes, if I can't get my patients active, cardiac rehab is a really good partner because it's consistent, it's a schedule, and patients go there and you're working with a team to get your patients more active. But we really want to be looking at these classifications 1 through 4 based on that activity level. So if I have a patient who's no longer going to check their mailbox anymore, I want to figure out why. Are they feeling marked limitation in their physical activity because they're so uncomfortable, right? So it's a lot of functionality that we focus on with this classification system in our heart failure patients. Management, a lot of non-pharmacologic management from us as primary care clinicians. We want to make sure we're getting them into cardiac rehab, getting them active. They understand what the cardiologist told them about the fluid monitoring, the daily weights, and what they should do with their medications and their diuretics. A lot of patients kind of don't understand that. We have to reiterate that. What they're doing with their fluid restriction, their diet restriction, making sure they're active, they're moving, wearing compression stockings to get that fluid back up, and also elevating their legs when they are sitting down, and then also making sure they're watching the salt in their diet. But I put that down there anyways. And some of them might be on home oxygen. Pharmacology. So again, I'll do a separate lecture on this, but this is going to be initiated by cardiology. If you're really suspecting heart failure, they need that echocardiogram. Cardiology will start them on the pharmacology. We're going to be co-managing them with cardiology to make sure patients understand the medications they're taking, why they're taking it, and the schedules that they're on. That's really important. All right, you guys, we got through all of it and it's the top of the hour. I appreciate you guys joining me today. This is really something I'm passionate about, and I wanted to make sure you guys got this content today so that you can best serve your patients. And I know you guys are going to do a wonderful job serving your patients. And um, stay tuned for more webinars about advocating for our role as nurse practitioners and making sure that we know our place in the healthcare system, we know how valued it is, and we advocate for our role. That's really, really important. For those of you, so a couple of you are sitting for the boards exam that were on the webinar today, make sure you guys check out our QBank. We have a free demo on that. We have over 1,600 questions and also readiness predictors. What I always tell people is our sure pass method, and this is what I work with my students on, is basically identifying those knowledge gaps and working on those knowledge gaps to make sure that you not only are board ready, but you're ready for your clinical practice. So our sure pass method says, watch our on-demand videos. We have over 16 hours of content. I think it's actually a little bit more than that because we added those clinical skills videos, those advanced clinical skills videos. So I think we're way more than 16 hours, but it's nice bite size. So you can go to the cardiology section, focus on the parts that really confuse you. You see those parts or parts that you're struggling on with those Q banks. So we always recommend watching the videos, 1 or 2 videos, and then going and practicing in those sections about 25 to 50 questions a day, and then periodically taking those readiness predictors. And if you're scoring high or very high on 3 to 4 readiness predictors consecutively, then that's our sure pass method. You are ready to sit for your boards. I work with students one-on-one, not to get you just ready for your boards, but for clinical practice. So reach out to me. Here's my email on the website. I think I'll also put a QR code on here for tutoring, but you can schedule either a tutoring session or a mentoring session with me. I'd love to work with you. And I really want to make sure that you feel supported and you have the support you need to thrive in this beautiful field. We also have our SurePass Pro, which lumps in that 2 hours of tutoring along with our QBank and on demand. And right now we don't have a live review on the calendar, but we do have a on-demand live review that you can purchase through our SurePass. But stay tuned for when our next live review is going to be, and then join our community. So I couldn't get Instagram and TikTok working today, but we have over 1,000 followers now, which is great because we're so new. So that's a big milestone for us. Kudos to Annie for leading our social media and getting us to out there and helping students see that there's this resource for you guys. We love helping and supporting nurses across all of the spectrum, whether you're just starting out or you're experienced. It's really a passion of ours and a community that we like to foster. But you guys can follow us on Facebook, scan this for our Facebook group. We also have these webinars available on our YouTube channel. So there are a lot of different ways to engage with our community, and we definitely welcome you guys to engage. But thank you so much. I'm going to launch this last poll before I forget. But how do you feel after the webinar today? Do you feel like it was useful? Do you feel like you learned something? You walked away with some knowledge? How do you guys feel? Oh, and a lot more people joined. Wow, hello. I didn't see it. I was busy chatting. But how do you guys feel after the webinar today? Do you feel like it was helpful? And then my next poll is going to be what other content do you guys want to see? And you won't hurt my feelings if you don't feel like it was helpful. It's really just more of a learning curve for me to make sure I'm tailoring these webinars to make it helpful for you guys. And I appreciate you guys being patient with me with my dry mouth and getting over the hump of being sick. I'm looking forward to having my brain back in a few days. Oh, I see. Okay, so I'm seeing some people in the chat saying that they thought the webinar was starting at 11 Central Time, not 10 Central Time. Oh my gosh, was that my blooper? Oh, sorry guys, let me take a look. No, I had 10 Central Time in my calendar. Oh, how weird. So some people are saying the dashboard said the webinar was starting at 11, not at 10 Central. Oh, I'm so sorry for the mix-up, you guys. Well, this is being recorded, so you guys can catch the webinar on our YouTube channel, and then I will go back and look at the dashboard and figure out what happened. But it said, oh, it said 12 Eastern time. Okay, I think there was a mix up there, so I apologize. So that makes sense why all of a sudden I saw a lot more people join. Oh, bummer, you guys. I'm sorry, but it is recorded, so you guys can go and watch the webinar, and I will follow up on the dashboard and figure out what happened, and hopefully we'll fix it for the next one too. But I do apologize. I was out sick for a couple of days, so I think the team was doing their best, but a lot fell on their shoulders, and I really appreciate their help in letting me recover. So I think there was some mix up with this webinar today. Today's my first day back in office. Oh, sorry, you guys. Well, our last poll is, what content would you like to see? Today's webinar. Sorry. Oh, I feel bad. The time indicates on the Archer website too. It's an internal blooper. Yeah, definitely watch the recording, you guys. All right. Well, I hope you guys have a lovely rest of your Friday. Enjoy the holiday weekend next weekend. And I will look out for what happened for today's webinar and make sure it's corrected on our dashboard for future webinars. But check out the recording on our YouTube channel. And we have the July calendar up as well. So definitely check out the July calendar coming up. But you guys have an awesome day, and thank you for joining today, and thank you for all of your participation. You guys were awesome. So we can't share the PDFs of the webinar, but you can go watch it on our YouTube and Facebook channel. That's okay. I knew you meant PDF.